Okay. So, good afternoon. I am Dr. Ankita. I am a DM clinical pharmacologist. I have done my DM from NIMS, and today I'll be discussing on the topic the drugs which are used in glaucoma. So, as we know that glaucoma is a very important condition and a very important topic for NEET PG because it's a sure shot question in every exam. So, having a mastery over this topic would help us to answer those few questions which mostly come from this topic. So, I'll start with the definition of glaucoma. What is glaucoma? That glaucoma is a neurodegenerative disease. It is a disease which is characterized by the progressive loss of retinal ganglion cells as well as their axons. Because of this progressive loss of retinal ganglionic cells, there is a damage to the optic nerve, and there is a characteristic appearance of the optic disc which is visible in glaucoma patients, and it is also associated with visual field effects, irreversible visual field effects. All this occurs mostly because of increase in intraocular pressure. So glaucoma, as we know, it is a very third leading cause of global blindness, which comes only after refractive errors and cataract. So why should now we should know something about the intraocular pressure, because this is the major causative agent for glaucoma. So to know about the intraocular pressure, what is the normal range and what is abnormal? So normal range for intraocular pressure is 10 to 21 mm of Hg, which is seen in a normal eye. And there are various factors which determine the level of intraocular pressure. Intraocular pressure occurs mainly because of the aqueous humor fluid, and thus the level of intraocular pressure is mainly based upon the rate of aqueous secretion, how much aqueous is secreted into the eye from the ciliary process in the eye, as well as it is also based on the outflow channels, resistance present in the outflow channels, and the level of episcleral venous pressure. All these three factors mainly determine the level of intraocular pressure in a normal eye. IOP also has a diurnal variation pattern. It is a physiological pattern in which there is around 3 to 4 mm of Hg variation in intraocular pressure from morning to evening. Morning there is a higher IOP, and in evening it drops down. This normal in a normal eye it is around 4 mm of Hg, but in glaucomatous eye it doubles and becomes around 8 mm of Hg. So this is important to know about the normal IOP in order to understand what is abnormal, and it is a major reason or the risk factor for glaucoma. By our What is the main aim of our glaucoma treatment is to lower this intraocular pressure. We can do this either by decreasing the production of aqueous humor or by increasing its outflow. By doing this, we can delay the damage to the optic nerve and we can preserve the vision. This slide helps us to understand it more clearly. What is the how this aqueous humor is produced and how it is drained. So we can see that it is in the slide. It is visible that it is produced from the ciliary body, ciliary epithelium. The aqueous humor is produced, and from this it flows into the posterior chamber, which is bound by the lens posteriorly and by the iris anteriorly. From here, this aqueous humor then flows into the anterior chamber, which is bound from the iris posteriorly and anteriorly by the cornea. From there, it is drained into the trabecular meshwork. You can see it here. The trabecular meshwork is here. It is drained in the trabecular meshwork, and then by the scleral venous sinus or the Schlemm's canal, it goes out and joins the general blood circulation. This is the major pathway or the trabecular outflow pathway. There is an alternative outflow pathway also, that is a uveoscleral outflow pathway from the uvea, that is the iris, to the sclera, uveoscleral outflow pathway. So these two are the major outflow pathways, and the inflow is through the ciliary body epithelium. So the drugs which we are going to discuss mainly target these pathway. Either they decrease the inflow. The major class of drugs which decrease this inflow include beta blockers, alpha agonist and carbonic anhydrase inhibitors, and the drugs which increase the outflow, which include prostaglandin analogs, cholinergics, and alpha agonists. In this, you can see that the alpha agonists are present both for decreasing the inflow as well as increasing the outflow of the aqueous humor. So it has a dual mechanism of action. This is another diagrammatic representation of the structures of the anterior chamber, in which you can see the site of action and the receptors which are present all over the anterior chamber of the eye. In this, we can see that the ciliary muscle and the ciliary epithelium contain the alpha and the beta receptors. So these alpha and beta receptors are mainly responsible for aqueous humor production. Then the iris sphincter muscle as well as the iris dilator muscles, they contain the muscarinic and the alpha receptors. And then there is trabecular meshwork, which contains the ROCK receptors. This is the newest addition, ROCK inhibitors or Rho kinase inhibitors, which we will be discussing in the recent advances in the pharmacotherapy of glaucoma. Now coming to the major drug classes for glaucoma, we can see that the primary or the most important ones are the prostaglandin analogs, beta blockers, alpha agonists, and carbonic anhydrase. These are the primary drug classes. And then there are secondary drug classes, which are used as an add-on drugs to the primary ones, which include acetylcholinesterase inhibitors or cholinergic agonists, and very rarely are non-selective adrenergic agonists used. Now they are not used commonly because of their adverse effects. Now coming to another classification, which we have already discussed in the previous slide, that is the drugs which suppress the aqueous humor production and drugs which increase the aqueous outflow. So coming to again stressing on the point, alpha agonist, beta blockers, and carbonic anhydrase are the drugs which decrease the aqueous production by acting on various receptors. Alpha agonist acting on alpha 1 and alpha 2 receptors, beta agonist acting on beta 1 and beta 2 receptors and blocking them, and carbonic anhydrase inhibitors which act on the carbonic anhydrase enzyme. Then there are aqueous outflow drugs which promote the trabecular meshwork outflow or the unconventional outflow, which is the uveoscleral outflow. These are the two outflow pathways. The various drugs which are in this class include cholinergic drugs and Rho kinase inhibitors, which increase the trabecular meshwork outflow. And there are unconventional outflow or the uveoscleral outflow pathway, which is the prostaglandin analogs. So the list of these drugs will be discussed subsequently. This is a graphical representation in which we can see how the drug development took place. The pilocarpine, which was the first topical drug which was used to treat glaucoma. Now, this timeline shows from 1876, pilocarpine was used, and now coming to the year 2018, a newer drug has come up, that is omnidipac isopropyl, which is a prostaglandin E2 analog. And this has been now approved in year 2022 to treat open angle glaucoma. This is the recent addition, omnidipac isopropyl. This is a prostaglandin E2 analog. So this is the timeline for the introduction of IOP lowering drugs. Now, first and the foremost, most important class of drug, which is the first line for the treatment for glaucoma, is prostaglandin analogs. So there are three formulations for prostaglandin analogs, which are most commonly used. That is the latanoprost, travoprost, and bimatoprost. These are the three formulations, and they are all of them are given once daily. How do they act? What is the mechanism of action is the most important for us to know. And these act by acting on the PGF2 alpha receptors. PGF2 alpha receptors are the receptors which are present in the circular and the connective tissue of ciliary muscles. And these receptors, when they are activated, they increase the metalloproteinases expressions. 1, 2, 3, and 9 metalloproteinase expression in the ciliary muscles. They increase the expression of this metalloproteinases. By increasing the expression of this, they result in the remodeling of the ciliary muscle bundles, which causes increased uveoscleral pathway outflow. This is the major mechanism of action of prostaglandin analogs. The drugs which we use are latanoprost and travoprost, which are the PGF2 alpha analogs, which bind to the prostaglandin receptors. They're present in an inactive form, that is in a ester form they are present, and they have to be converted to free acid in order to be active. So they get converted to free acid by presence of enzymes such as esterases, which are present in the cornea. Those enzymes break down this latanoprost and travoprost and convert them into free acid, which is the active form for the action at prostaglandin receptors. All the three drugs, that is latanoprost, travoprost, and bimatoprost, all of them are given as once daily dosing, and they are effective in reducing the 24-hour intraocular pressure. Now coming to the response, intraocular pressure response. The expected lowering of intraocular pressure is around 30%, which is the highest IOP lowering amongst all the glaucoma drugs. And the onset of lowering occurs within 2 to 4 hours. Peak is reached within 12 hours, and the washout takes around 4 to 6 weeks. So from this diagram, you can see that this is the baseline of the intraocular pressure with the diurnal variation. It becomes lower in the night, higher in the morning. And by giving latanoprost, we can see if it is instilled at the night, it effectively controls the intraocular pressure even in the morning. There is a great decrease in the intraocular pressure even in the morning. So it has a very long half-life with long duration of action. What are the interaction with other drugs? Because it is a very good additive with all the anti-glaucoma drugs, only it has a concomitant use with cholinergic should be avoided because they have mutually antagonist reactions. So it should not be given with cholinergic or parasympathomimetic drugs, but it can be given with any other class of anti-glaucoma drugs. The side effects, which is a major question now for exams, that we should remember for each and every class of drug, the side effects are very important, which we have to memorize and try to remember. So the side effects associated with the prostaglandin analogs very commonly are the lash changes. What happens is that there is a thickening and darkening of the eyelashes, which is seen with these drugs. Also, there is increase in pigmentation, iris and the periocular skin pigmentation. These drugs are pro-inflammatory. They cause hyperemia of conjunctiva also. They can cause uveitis, reactivation of keratitis. So it is associated with many side effects, but most of them are mostly localized side effects and not very severe side effects which lead to discontinuation. So because of all these reasons, the prostaglandin analogs have been approved by FDA as the first line treatment for increased IOP associated with open angle or ocular hypertension. The reason for recommending them as a first line agent is because of their high efficacy of around 30% lowering of IOP, limited systemic side effects. They have only local side effects. Systemic side effects are nil, and they require only once a day dosing. So because of these three reasons, they are approved as a first line treatment for increased IOPs. Now coming to the second major class of drug, beta blockers. Previously, few years back, beta blockers were the first line drugs. Now prostaglandins have come up as the first line agents. So beta blocker preparations are of two types, non-selective and beta 1 selective. So beta blockers non-selective, that is, they act on both beta 1 as well as beta 2 receptors, which include timolol and levobrinolol. These are given as 0.25 and 0.5% preparations. Levobrinolol has a additional benefit is that it has a longer half-life than timolol, and thus we can give once daily dosing for levobrinolol. These are non-selective, have action on both beta 1 and beta 2. Then there is betazolol, which is beta 1 selective. And because of being beta 1 selective, it has no action on beta 2. So it avoids the CNS as well as pulmonary side effects. And thus we can give it in patients with respiratory issues. Also, it has less absorption than timolol. It is less efficacious than timolol, but it is safer in respiratory patients with respiratory problems. Also, newer ones are with intrinsic sympathomimetic activities like cartilol and pindolol, but these are not very commonly used. Now, very important is to know about their mechanism of action. As we have seen in the previous slide, is that they decrease the aqueous humor production by blocking the beta adrenergic receptors, beta 2 adrenergic receptors, which are present in the ciliary epithelium. By acting on those receptors, they decrease the aqueous production, and thus they can be given as BD dosing. And they should be given mostly in the morning because they are less effective during night time, because the aqueous humor production decreases during the night. It is higher in the morning and lower in the night. So mostly preferably it should be given in the morning. It has a good IOP lowering response of around 25%. Peak is reached within 2 hours and washout takes around 2 to 5 weeks. So it has second additive agent to parasympathetic to the first prostaglandin. This is the second one, which is very efficacious. Now coming to the side effects, it has multiple side effects. The major issue with beta blockers is they have multiple side effects, and those are not only limited to the ocular, but they have systemic side effects also, which are the major limitations for the use of beta blockers. So to know about the major side effects, ocular adverse effects are the conjunctival hyperemia as seen in patients taking prostaglandins also. blepharoconjunctivitis, epithelial keratopathy, and decrease in corneal sensitivity. These are the ocular adverse effects, but most of them are mild side effects. The systemic side effects are the major limitations, which are bronchospasm, arrhythmias, bradycardia, CHF, syncope, hypertension, depression. All these are a lot of side effects with the use of beta blockers. And they're absolutely contraindicated in patients with asthma, bradycardia, heart block, and acute CHF. Now coming to the alpha-2 agonist. So about alpha-2 agonist, they are also a non-selective and selective. So first one is the apraclonidine, which is available in 0.5 and 1% formulation, which can be given as BID or TID dosing. It is non-selective, thus it acts on both alpha-1 as well as alpha-2 receptor. And the alpha-1 is present in the ciliary blood vessels. Alpha-2 is present on the ciliary epithelium, and acting on both these receptors, it decreases the aqueous production. However, they are only used, they have a lot of side effect, the major side effect being allergic blepharoconjunctivitis, and thus it is used only for short-term prophylaxis, mostly after to prevent IOP increase after any laser procedures. So they are used only for short-term prophylaxis only. It is a non-selective agonist. Now they have been replaced by selective agonists such as alpha-2 selective brimonidine. This has dual or triple action. It decreases aqueous production as well as it increases uveoscleral outflow. And uveoscleral outflow also forms one of the major reasons for using it as a chronic agent for around 1 year. It also has additional action of neuroprotection. How does it provide neuroprotection is that it causes upregulation of BDNF, that is brain-derived neurotrophic factor, which is present in the retinal ganglion cells. And because of this, it has an additional action of neuroprotection. It can be used as a neuroprotective agent also. So amongst apraclonidine and brimonidine, brimonidine is better because of its selective alpha-2 selective action as well as action on the uveoscleral outflow. Now coming to the IOP response, we expect around lowering of 20 to 25% with this alpha-2 agonist. Peak is reached within 2 hours and washout takes around 1 to 3 weeks. The side effects which are associated with alpha-2 agonists are follicular conjunctivitis or allergic blepharoconjunctivitis, as I told, which is very high, around 50% with the patients using apraclonidine. Thus, apraclonidine use has gone very down. It is only around 15% with brimonidine. Other side effects include fatigue, eyelid retraction, dry mouth, and hypotension. And one important point to know is that it can cause apnea in infants and young children. So it is completely contraindicated. It should never be used in smaller children because it crosses the blood-brain barrier. And by crossing the blood-brain barrier, it can cause depression of the CNS as well as respiration. And thus, alternative glaucoma therapy should be considered in infants and young children. Alpha-2 agonist use should be discouraged. Now coming to the other class of drug, that is carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors are the drugs which belong to sulfonamide group of drugs, and they are the only class of IOPs which are available in both topical and oral formulations for treatment of glaucoma. So topical formulations are dorzolamide and brinzolamide, which are given in BID to TID dosing, and the oral formulations are acetazolamide and methazolamide. Oral formulations can be used as an add-ons to the topical, but not vice versa. Only oral can be used as an add-on. In patients with renal disease, we can use methazolamide because it is not metabolized by the kidneys. It is liver metabolized. We can use methazolamide in renal disease patients. It is safer in renal disease. Acetazolamide use is mainly for short-term indications. Before and after surgery, after laser therapy, we can use acetazolamide. Now coming to the mechanism of action. It is clear from their name, carbonic anhydrase inhibitors, they inhibit the carbonic anhydrase enzyme. What happens is that both the topical and the systemic carbonic anhydrase, they reduce aqueous humor formation. How do they do that? Is that they inhibit the carbonic anhydrase 2 isoform in the epithelial cells of the ciliary processes. By inhibiting this, they decrease the formation of bicarbonate ions and thus decrease the fluid accumulation in the posterior chamber. So that is the major mechanism of decreasing the aqueous production. And also additionally, they increase the ocular blood flow. Their response is around 15 to 20% of IOP lowering. Washout takes around 1 week. For topical and oral, it takes around 3 days. What are the side effects? Now, carbonic anhydrase inhibitors are associated with multiple side effects. Because of so many side effects, systemic carbonic anhydrase inhibitors like acetazolamide, they are avoided for long-term therapy. They are given for short-term therapy only because of multiple side effects with systemic therapy, ranging from paresthesia, depression, loss of appetite, GI symptoms, acidosis, in electrolyte imbalance, multiple side effects with systemic formulations. So we prefer topical formulation only. The side effects associated with topical are stinging, burning, foreign body sensation, and with brinzolamide, there is also transient blurring of vision. And because they are sulfonamide drugs, they are contraindicated in patients who are having sulfonamide allergies. Now coming to the last group of drugs, that is the parasympathomimetic drugs or the cholinergic drugs. How they are given, that is the pilocarpine, which is commonly used, which is available in 0.5 to 4% formulation, and also available in gel form, which can be used once daily. Also, there is carbachol. Pilocarpine was the oldest and the first drug which was used for glaucoma treatment. What is the mechanism of action? Is that they increase the trabecular meshwork outflow. How do they do that? Is that by the stimulation of the muscarinic receptors. The iris ciliary body trabecular meshwork has mainly M3 type of muscarinic receptors. By stimulation of these receptors, the ciliary muscle gets contracted. By contraction of ciliary muscle, the scleral spur is pulled back, and there is widening of the network, trabecular meshwork, and there is an increase in the aqueous humor outflow. So it acts on the M3 receptors, and contraction of smooth muscle fibers leads to increase in aqueous humor outflow. It causes a lowering of around 10 to 20% of IOP by 1 hour post instillation and takes around 3 days for the washout of the drug. What are the side effects? There are several drawbacks because of multiple side effects with cholinergic drugs, and thus they are used least commonly nowadays for glaucoma treatment. They are pro-inflammatory. It causes myosis because of contraction of iris sphincter muscles.
Hello, doctor.
Yeah.
So sorry to interrupt. How many
Yeah.
more slides are remaining?
I think 10 more are there.
Okay, and you have included MCQs, right?
Yeah, last 3 or 4 slides are MCQs only.
Okay. Because those are most important, because this more or less they have understood like your flow and everything. Like
Yeah.
if you can wrap it up quickly, that is fine. But please make sure that those 3 slides to be covered. I
How
think
much time is remaining?
12 minutes. That's fine.
Okay, so I'll just go quickly over these slides
Yes,
then.
yes,
I
yeah.
will go to the MCQ slides
Okay,
first.
okay.
Okay. So,
Please.
okay, the side effects which we have discussed, it causes myosis by contraction of iris sphincter muscles. Because of myosis, there is broic and causes visual field constriction also, shallowing of anterior chamber, cataract, and decreased vision at night. There are multiple drawbacks because of parasympathomimetics, and thus it is avoided or used least commonly. Now coming to the novel targets or the newer agents for treatment, the recently which has come are the ROCK inhibitor or Rho kinase inhibitors. Also, nitric oxide donors are the other group of drugs which have come recently and have been approved recently. So those two we will discuss. Others which are still under phases of development are adenosine receptor ligands, oligonucleotide-based compounds, gene and stem cell therapy, and neuroprotection. These are the other which are under research nowadays. And these are the various novel targets which are still under research. We can see Rho kinase already approved. Others are still under various phases of clinical trials. These are the targets. Now coming to the Rho kinase inhibitors, a little brief about the Rho kinase inhibitors. The 2 drugs which have been approved are nitarsudil and ripasudil. So nitarsudil and ripasudil, they are approved, are the only available Rho kinase inhibitors. Nitarsudil, which has got approval by FDA in 2017. After 20 years of waiting for any new glaucoma drug, this is the first drug which has been approved. They have multiple mechanisms. They increase the outflow of by increasing the outflow from the trabecular meshwork. They inhibit the fluid production also, and they also lower the episcleral venous pressure. By these multiple actions, the rho kinase inhibitors act, and thus their use their new use has come up because of multiple mechanisms. Other ones are nitric oxide donating prostaglandin analog. This is another newer agent which has come into the market recently, that is latanoprostene bunod. Latanoprostene bunod is a new agent which causes, it is a nitric oxide donating prostaglandin receptor agonist. It has a dual mechanism of intraocular pressure narrowing. How does it act? Is that this latanoprostene bunod is metabolized to latanoprostene and butanediol mononitrate. It releases nitric oxide. So it has action by latanoprost, it increases uvoscleral outflow, and by nitric oxide, it increases trabecular meshwork outflow. So it increases the outflow of both uvoscleral and trabecular meshwork. So dual mechanism of action. It is also associated with few side effects such as conjunctival hyperemia, eyelashes growth, eye irritation, and eye pain, and iris pigmentation. This diagram depicts its dual mechanism. First one is the FP receptor mediated or prostaglandin receptor mediated mechanism of increasing uvoscleral outflow, and second one is the nitric oxide mediated mechanism by increasing the conventional or the trabecular meshwork outflow. Dual mechanism of action of latanoprostene bunod. This is a brief summary of the various strategies to decrease the IOP lowering strategies. We have already discussed the increasing TM outflow, increasing uvoscleral outflow, and decreasing production. We have already discussed. Other ones are the which are new in the market under research. They have not been approved. They are still under trials. The other are the neurotoxicity or neurodegenerative strategies. These are the other which are still under various agents which are still under research. Now, what is the treatment plan? First, when we diagnose a patient with glaucoma, we give monotherapy. The agent of choice is prostaglandin analogs most commonly. Others are beta blockers or carbonic anhydrase inhibitors. If it is well tolerated, we continue with that. However, if the target IOP is not reached, we switch to another monotherapy or add a second drug. If the target IOP is reached, we verify the endpoints periodically. But still, after adding a second drug, if target is not reached, then we have to substitute the second drug and add another second drug, or we can go for surgery or laser. This is the way in which we treat a patient. When should we switch or when should we add? If the first choice of monotherapy, with the use of first choice monotherapy, if the IOP is not decreased by more than 15%, we have to switch. If it is partially effective, it is decreasing IOP by more than 15%, we can still, but target IOP is not achieved, we can add another agent. By this, we can treat the glaucoma. There are new drug delivery implants also which are coming in the market, which can produce sustained release of drug and which can be used. These include periocular inserts, canalicular plugs, sprays, subconjunctival implants, and anterior chamber implants, and iDose travoprost. But still, they have adherence problems and they have multiple issues such as safety and duration of IOP lowering, quality of life, and cost. And all of these, because of all of these reasons, they are not used still very commonly in glaucoma patients. They have high cost and still their safety is still not demonstrated. So I'll just finish off it with few important previous year questions which come for glaucoma. And the first and the foremost is, which of the following anti-glaucoma medication is unsafe in infants? So there are four options. And first is timolol, brimonidine, latanoprost, and dorzolamide. So we have seen in the previous slides that brimonidine is which it can cause apnea in infants and young children because it crosses the blood-brain barrier and it can cause CNS suppression as well as respiratory suppression. So it should never be used in infants, and alternative glaucoma therapy should be used. Other agents like timolol, latanoprost, and dorzolamide, these can be used in infants, but brimonidine use is discouraged because it crosses the blood-brain barrier and thus it can cause apnea and respiratory issues in children. Then the second question is, which of the following can be prescribed in case of an open angle glaucoma patient which is suffering with bronchial asthma? So which can be given? Timolol, Gemiprost, latanoprost, and mannitol infusion. We know that timolol is a beta blocker and it is non-selective, so its use is discouraged or contraindicated in bronchial asthma patient. Amongst all of these drugs, latanoprost is the most effective once daily drug, high quality, high efficacy, and less adverse effects. So the answer is latanoprost, which is prescribed in a patient with open angle glaucoma with bronchial asthma. Then the last question is, which novel therapy works by inhibiting Rho kinase inhibitors? So the options are nitarsudil, pilocarpine, brimonidine, or dorzolamide. So just in the novel targets, we saw that nitarsudil acts on the Rho kinase receptors ROC1 and ROC2, which are present on the trabecular meshwork, and by acting on those receptors, they increase the trabecular outflow. So these are the Rho kinase inhibitors. This is the newer agent nitarsudil, which has reached the FDA approval in 2017. Pilocarpine is a very old drug, which is a parasympathomimetic. Brimonidine and dorzolamide are the alpha agonists. So Rho kinase inhibitor is nitarsudil. That is the answer for this question. These are the references from which I have taken the reference and tried to make a brief presentation. Thank you. Yeah, I'm over with my
Yes,
talk.
doctor. Yeah.